Thank you so much, and we're really excited to present on this topic today. So just an outline of the talk, we're going to give a brief genetics primer, very basic, and it may be a review for most, but it's critical to understanding how to approach genetic diagnostics. Then we'll review the genetic types of genetic testing and what they test for and their limitations. We'll discuss interpretation of variants and use of ancillary testing to resolve variants of uncertain significance. And lastly, we'll have some pediatric neurogenetics cases to illustrate the concepts and principles. So why is it important to arrive at a genetic diagnosis? When we have a diagnosis, we can educate the patient and family about the disease and the disorder and provide anticipatory guidance and prognosis. We can counsel families about the risk of recurrence. And in the era of therapeutics, many diseases have targeted treatments available and are now amenable to genetic therapeutic approaches. So from a very basic overview of the genetics of disease, so each of us has more than 1 trillion cells that make up our body, and each of our cells contains genetic material or DNA, and most of the genetic material is tightly wound into chromosomes, and those are stored in our nucleus as nuclear DNA. DNA is our body's instruction manual on how our body develops and functions, and each gene provides instructions for how our body makes proteins. In addition to nuclear DNA, our cells also contain mitochondria, and there's thousands of mitochondria which are necessary for energy production in our cells. And the mitochondria have their own genetic material. Our DNA and each gene is made up of nucleotides, A, G, T, and C. And these are read in sets of 3 to make up proteins, and each set of 3 is a codon that codes for a single amino acid. And after all codons are read and each amino acid is made, a protein is ready to be formed, and a stop signal indicates that the protein is complete and no additional amino acids are added. How our body reads the DNA in these sets of 3 is called the reading frame. So this slide shows an analogy for the processing of genetic information by our cells. So cells read DNA and transcribe it into RNA molecules. The messenger RNA is translated into proteins, which are 3D structures within the cell that are essential for almost every process in living cells. And this process, the process of building proteins in the cell can be thought of as a construction site where construction workers, which are the RNA, read the blueprint DNA for the instructions on how to build the buildings or the proteins. And copies of the blueprint are passed from parent to child, and a copy of each gene is inherited by a child from their parent. How diseases and traits are passed and expressed from parent to child is the pattern of inheritance. And autosomal dominant inheritance means that one copy of the gene on a chromosomes 1 to 22, the autosomes, is enough to cause symptoms or features of a condition. One copy of the gene is working as expected, while the other copy is not working as typical. A single abnormal copy of the gene from one parent is enough to cause the disorder. A child of a person affected by an autosomal dominant condition has a 50% chance of being affected by that condition via the inheritance of the dominant allele. Autosomal recessive conditions are caused by changes in the genes on chromosomes 1 to 22, the autosomes, in which variants on both copies of the gene are necessary to cause symptoms of the feature or the condition. Features of the condition, and neither copy of the gene is working properly. And this can be caused by the same variant on both copies of the gene or 2 different variants that are pathogenic, one on each copy of the gene. X-linked conditions are caused by changes to the gene on the X chromosome. In the cases of X-linked disease, it's usually males that are affected because they have a single X chromosome that carries the disease-causing variant. In females, the presence of a second non-mutated copy may cause different or milder or no symptoms of a sex-linked disorder. There's no male-to-male transmission in the cases of X-linked disease. The de novo variant is a new variant that occurs spontaneously and is unique to the proband or the child and is not passed from a parent. It happens spontaneously when the individual is developing in utero. And lastly, mitochondrial DNA or mtDNA is the circular chromosome found in mitochondria, encoding for proteins needed for mitochondrial function. Nuclear DNA also codes for important mitochondrial proteins in addition to the proteins coded for by the mitochondrial DNA. Offspring inherit their mitochondria, and as a result of the mitochondrial DNA, and received those mitochondria from their mother. The idea of zygosity, it refers to the versions of the alleles of a gene inherited from each biological parent. Heterozygous, as related to genetics, refers to having inherited different versions of alleles of a genomic marker from each biological parent. Thus, an individual who is heterozygous for a genomic marker has two different versions of that marker. By contrast, an individual who is homozygous for a marker has identical versions of that marker. Here, homozygous and heterozygous variants are depicted in another way. You can see compound heterozygous refers to two variants in the gene which are different from the variants in the same gene. So when variants are on different copies of the gene, they're in trans. And when they're on the same copy, so on the same chromosome, then they're in cis. The concept of hemizygosity refers to when one variant is found on the only copy of a gene, for instance, on the X chromosome in males. Once a variant has been identified in a nucleotide position, the variant is named, and variants in a gene are named based on the transcription and the protein location. And the protein level variant nomenclature, which is the amino acid residue that's affected by the underlying nucleotide level change, is used to describe the predicted effect of a variant on a protein. So transcript level changes include substitutions when you substitute one nucleotide for another. Deletions, for instance, 485 to 488 deletion, is a deletion of 4 nucleotides from a gene from the position 485 up to including 488. Duplication is when nucleotides are duplicated within a gene, and insertion is the insertion of nucleotides at a position. Protein level consequences of the transcript change include nonsense changes, denoted by an asterisk, which code for a stop codon, and therefore no protein is made. Frame shift variants, for instance, asterisk 7, denotes a new premature stop codon occurs 7 amino acids downstream of where the deletion occurs, and a truncated protein is formed. In-frame duplications are when a single amino acid is duplicated, or multiples of 3 amino acids are duplicated. And then missense or synonymous variants are when the protein, the amino acid code is still coded for, even though there's a nucleotide change. Silent or synonymous means the same. And then when you see the question mark, it means it's an intronic change. So we all have changes in our DNA or different spellings that are called variants, and there's 2 main types of variants: copy number variants, or extra or missing duplications or deletions. If genetic material is a shelf of instruction manuals, a copy number variant is when a person is missing books or has extra books. Copy number variants are typically named for their locations. For example, 19p13.3 is described as a deletion on the small arm of chromosome 19. So P is the small arm, Q is the large arm. And the numbers, i.e. 13.3, tell us exactly what band or stripe of the chromosome has been deleted. Sequence variants, or SNVs, are changes to the letters of the gene or the spelling change. A person has the typical number of books in their library, but there's a change in the spelling in a sentence of one of the books. A copy number variant is a large amount of extra or missing genetic material. So duplications, a copy of a portion of the DNA sequence is repeated. 1 or more copies of the DNA segment are repeated, which can be as small as a few bases or as large as a major chromosomal region, or even a full gene duplication. Another type of copy number variant includes insertions, deletions, or indels. Insertions involve the addition of any number of nucleotides from a single nucleotide to an entire piece of a chromosome. Deletions include removal of nucleotides from the DNA sequence, and then indels are when insertions and deletions co-occur, removing nucleotides from the DNA sequence and inserting a different DNA sequence. Sequence variants mean a spelling change found within a gene. A point variant occurs in a genome when a single base pair is changed or substituted, removed or deleted, or added or inserted. While most point mutations are benign, they can also have various functional consequences, including changes in the gene expression or alterations in the encoded proteins. Functional consequences of point variants include synonymous variants, which are changes in the DNA sequence that do not cause any changes to the amino acid or the protein. Different codons, as I had mentioned before, can code for the same amino acid. Missense variants is a DNA change that results in different amino acids being encoded at a particular position in the resulting protein. And some missense mutations alter the function of the resulting protein. And nonsense variants occur in DNA when a sequence change gives rise to a stop codon rather than a codon specifying an amino acid, and the presence of a new stop codon results in the production of a shortened protein that is likely non-functional. A frameshift variant frameshift variant in a gene refers to the insertion or deletion of nucleotide bases in numbers that are not multiples of 3. This is important because a cell reads a gene's code in groups of 3 bases when making the protein, and each of the triplet codons corresponds to one of the 20 different amino acids used to build a protein. If a variant disrupts the normal reading frame, then the entire gene sequence follows the mutation will be incorrectly read. In-frame variants occur when multiples of 3 nucleotide bases are inserted, deleted, or duplicated in a DNA sequence within the reading frame, and this adds or removes amino acids without affecting the rest of the amino acid sequence. Whereas frameshift variants occur when the number of nucleotide bases inserted, duplicated, or deleted is not a multiple of 3, and the reading frame shifts for all of the DNA letters after that that have been added or deleted, and it changes the gene's reading frame. Expansion of nucleotide repeat sequences within certain genes can be disease-causing and has been identified as the mechanism underlying a group of inherited conditions collectively known as repeat expansion disorders, which are sometimes called triplet repeat expansion disorders, as trinucleotide repeats are by far the most common. Repetitive sequences are inherently unstable during DNA replication and therefore are prone to expand or contract in length during DNA replication, both somatically and in the germline. Therefore, unlike other pathogenic variants that are usually passed unchanged from parent to child as a single nucleotide variant, deletion, duplication, and so on, repeat expansions are dynamic due to their tendency to change further in size during DNA replication. The type of genetic testing needed to determine is based on the variant type, so copy number variant versus a sequencing variant. For copy number variants, karyotype chromosome microarrays, array comparative genomic hybridization, or ACGH, and multiplex ligand dependent probe amplification, or MLPA, are the tests of choice. Karyotypes are used for chromosomal abnormalities, so extra or missing chromosomes, so trisomies, monosomies, for large translocations, and for very large copy number variants, which are deletions or duplications. A chromosome microarray is the investigation of choice for detecting copy number variants, small deletions, and duplications of stretches of DNA for greater than 250 kilobases. Genome-wide CMA has been endorsed as the first-tier test for several indications, including patients with autism, intellectual disability, global developmental delay, and with patients with multiple congenital anomalies. CMAs can also detect regions of homozygosity or chromosomal segments that are identical to one another. Identification of these regions of homozygosity enables the potential detection of conditions that can be caused by uniparental disomy, which occurs when a person receives the 2 copies of a chromosome or a part of a chromosome from only one parent. A limitation is that it cannot provide structural or positional information about the variants. ACGH is used to detect copy number variants such as deletions or duplications, and unlike a microarray, which is used to detect sequence matching a probe, ACGH can detect submicroscopic chromosomal abnormalities, but it can't detect balanced chromosomal rearrangements, point mutations, and some types of polyploidy. And MLPA is a good alternative to microarray when the gene to be investigated is known, so you know which disease you think you're looking at and what gene you want to look at. And MLPA is best for detecting small copy number variants, such as those on targeted gene panels. For sequencing variants, we typically look at types of gene sequencing, exome sequencing, repeat testing, and genome sequencing. So specific gene sequencing detects sequence variants in genes, either individual or multiple genes can be assessed at one time. So single gene testing looks for variants in a single gene, used when there's a known familial variant or when there's a specific genetic condition that's suspected. Multiple gene panels look for variants in multiple genes at once, often used when single gene testing is negative or when several or many genes are known to cause a genetic condition, for instance, for neuromuscular disorders, for epilepsy, et cetera. You can order specific gene panels that carry a vast array of the different genes that can cause those conditions. Exome sequencing looks at the coding regions, exons of genes associated with a person's symptoms and can be ordered with or without copy number variant calling to detect multiple exon deletions or duplications. Protein coding regions or exons of the genome are sequenced, and the exome makes up about 2% of the person's genome, but the vast majority of alleles underlying Mendelian disorders impact coding sequences. So that's the reason why we typically go to this first before genome sequencing. Given the breadth of information that's generated using exome sequencing and genome sequencing, parental samples are recommended for analysis, ideally a trio analysis or duo analysis if one parent is unavailable, since this can reduce the number of candidate variants that are required for review to facilitate variant interpretation. Exome sequencing is unable to detect repetitive DNA sequences, including trinucleotide repeats, intronic or non-coding variants, mitochondrial variants, epigenetic variants, and balanced balanced chromosomal rearrangements. Short tandem repeat testing is genetic testing of choice for repeat expansion disorders, and it looks at specific genes. As you can see in this image here, these different disorders are tested for with that. And genome sequencing looks at the sequencing level variants in coding and intronic regions of all known genes associated with a person's symptoms and can pick up repeat expansions as well. When looking at variant classification, gene variants can be associated with specific disease, but it's important to note that not all variants in a gene cause disease. And some individuals with disease-causing variants might not have the condition due to incomplete penetrance or variable expressivity. Variants are classified based on the ACMG and ClinGen guidelines, with benign or likely benign variants thought to not impact gene function and thought to not independently cause any significant health or developmental differences. Pathogenic or likely pathogenic variants are thought to impact gene function and contribute to disease. And variants of uncertain significance are when there's not enough information to determine if a variant will result in health or developmental differences, and more information is needed. And this is when you will perform ancillary tests or other diagnostic tests to help you resolve uncertain variants. So when reviewing and interpreting a genetic testing report, one should ask, does the genetic variant fit the clinical picture? The clinical manifestation should be consistent with the known phenotype in most cases. Is there further supplementary testing to support the diagnosis? So this could be imaging, histopathology, electrophysiology, evaluation of other organ systems. For variants of uncertain significance, then you need to amass subjective evidence of the disease process. Does the inheritance pattern fit? Does the variant segregate with disease? So for example, if a disease is inherited in an autosomal recessive fashion, then you need 2 variants to be causative of the disease. Or if an unaffected family member has the same variant, it should call the diagnosis into question and raise questions about reduced penetrance or phenotypic variability. Okay, so now moving on to some cases to help illustrate these examples and principles. So case 1, a male infant was delivered vaginally at 36 weeks gestation to a 42-year-old G5P4 mother. He was large for gestational age, weighing 45 grams. Physical exam revealed significant abnormal dysmorphic findings, including a round head, flat occiput, flat face, almond-shaped upward slanted palpebral fissures, small receding chin, short neck with redundant folds, a single bilateral palmar crease, stubby hands, clinodactyly, and this sandal toe gap deformity. At age 5 months, he began having abnormal movements described as bending forward or backwards, stiffening of the arms and legs, arching of the back, jerking body movements with facial grimace, and a video EEG captured episodes which were consistent with infantile spasms. So this case is consistent with trisomy 21 or Down syndrome. Here you can see the karyotype, which is how you would diagnose trisomy 21 with an extra copy of chromosome 21. The presence of all or part of a third copy of chromosome 21 defines Down syndrome, which is the most common chromosomal abnormality. In a patient with classical features of trisomy 21 should have a karyotype performed to identify the extra chromosome. And of note for the case that was presented, seizures can occur in about 5 to 13% of patients, and they can present as infantile spasms, generalized tonic-clonic seizures, or myoclonic seizures. Case 2, a female infant born at 39 weeks gestation by emergency C-section, which was complicated by frequent epileptic seizures, as well as hypotonia. Seizures progressed throughout the first few years of her life and became very difficult to control. She had global developmental delays. Facial dysmorphisms were noted in the form of a prominent forehead, bitemporal hollowing, short nose with upturned nares, thickened upper lip with a long philtrum, low-set ears, and hypertelorism. MRI brain showed widened lateral ventricles, poor gyral formation, and possible gray matter heterotopia. Unfortunately, the child passed away at the age of 4 years. Diagnosis is Miller-Dieker syndrome, or type 1 lissencephaly. Miller-Dieker syndrome is a neuronal migration disorder clinically characterized by classic lissencephaly, microcephaly, cardiac malformations, growth restriction, and characteristic facial features, including prominent forehead, down-slanting palpebral fissures, short nose with upturned nares, and protuberant upper lip and micronanthia. Death usually occurs in the first few years of life, and development remains at the 3 to 6 month level. Genetic mechanism-wise, Miller-Dieker syndrome represents a microdeletion syndrome spanning the PAFAH1B1 gene, also known or previously known as LIS1, at 17p13.3. Chromosome microarray analysis, or CMA, including or array CGH, is the gold standard diagnostic test to detect copy number variants in MDS. It's a dominant disorder. It's most often de novo. And about 12% of people with Miller-Dieker syndrome inherit a chromosomal abnormality from an unaffected parent. And in these cases, the parent carries a chromosomal rearrangement called a balanced translocation, in which no genetic material is gained or lost in the parent. But balanced translocations don't cause health problems in the parent often. However, they can become unbalanced as they are passed from one generation to the next. And so a child who inherits an unbalanced translocation can have a chromosomal rearrangement with extra or missing genetic material. Case 3, a 12-year-old boy with hyperactivity, attention deficit disorder, autistic behavior presents for neurodevelopmental evaluation. Examination reveals an elongated and narrow face with a large forehead, prominent chin, large and anteverted ears, and bilateral macroorchidism. The diagnosis is Fragile X syndrome. Male individuals with Fragile X have moderate to severe intellectual impairment and behavioral phenotype characterized by repetitive behaviors, social difficulties, poor eye contact, excessive shyness, anxiety, aggression, tactile defensiveness, and hyperarousal response to sensory stimuli, tantrums, attention deficits, hyperactivity, impulsivity, self-injury, stereotypic movements such as hand flapping, and then perseverative speech. Physical manifestations range from large forehead, prominent ears, hyperextensible finger joints, and macroorchidism. Features can include strabismus, seizures, musculoskeletal abnormalities such as pes planus, pectus excavatum, and scoliosis. And there's a cardiovascular phenotype with mitral valve abnormalities and aortic root dilation, and then behavioral disturbances. Fragile X syndrome is an X-linked repeat expansion disorder causing loss of function of the FMR1 gene. The schematic here illustrates the main molecular mechanism leading to Fragile X syndrome and FMR1 associated disorders. Fragile X syndrome is the most prevailing cause of X-linked inherited intellectual disability and autism spectrum disorder. It's caused by CGG, trinucleotide repeat expansion within the 5' UTR region of FMR1 gene located on the X chromosome. The CGG repeats expand in the female germline during transmission. And when the CGG expands to more than 200 repeats, the so-called full mutation, the promoter of FMR1 becomes hypermethylated and transcriptionally silent, leading to gene inactivation and consequently diminished or lack of expression of the FMR1 protein or FMRP. Individuals with Fragile X pre-mutations, which is 55 to 200 CGG repeats, are at risk of developing a number of clinical problems falling under the umbrella of FMR1 associated disorders. Several types of variants, including missense, nonsense, and deletions, have been reported. And the deletions in Fragile X individuals commonly range from hundreds to several millions of base pairs and frequently encompass a portion of the entire sequence of the FMR1 gene. For genetic counseling purposes, all mothers of individuals with FMR1 full mutation are carriers of a pre-mutation or full mutation, and reproductive risks are dependent on the mother's expansion size, and if the mother has a pre-mutation or if there are interruptions in the CGG repeats. There's a large, there's several targeted pharmacological therapies under investigation for this disorder, including several FDA-approved medications that are in use for other purposes, including metformin, minocycline, lovastatin, and sertraline. Case 4, a newborn baby has respiratory and feeding difficulties requiring admission to the neonatal intensive care unit. Examination reveals generalized hypotonia and bilateral club feet. CK is normal. Examination of the mother reveals impaired relaxation after hand grip and percussion myotonia. So the baby in this vignette has clinically congenital myotonic dystrophy. So myotonic dystrophy is a repeat expansion disorder. Congenital myotonic dystrophy occurs in myotonic dystrophy type 1 when the number of CTG repeats in the DMPK gene is greater than 1,000 and the symptoms are present at birth. The age at onset has an inverse correlation with the number of CTG repeats. So the higher number of CTG repeats, the earlier age of onset of the disease. CTG repeats between 50 and 1,000 can result in classic adult onset or childhood onset myotonic dystrophy type 1, in which the onset of symptoms is between the age of 1 and 10 years. Congenital myotonic dystrophy and childhood myotonic dystrophy represent a spectrum of the myotonic dystrophy type 1 disorder. Due to anticipation, the parent of a patient with congenital myotonic dystrophy, usually the mother more commonly than the father, may have classic myotonic dystrophy with fewer CTG repeats, and anticipation is the phenomenon when the number of multinucleotide repeats expands in successive generations, resulting in earlier onset and more severe symptoms. So you can see here, the expanded DNA is transcribed into pathogenic RNA, which disrupts the splicing of the CUG binding protein and muscle bind-like protein. This disruption causes splicing factors to become sequestered, forming ribonuclear inclusions. And these inclusions disrupt cellular signaling, which can lead to toxic effects on muscle metabolism and RNA processing. And so this process is called a spliceopathy. These changes prevent muscle cells and other cells from functioning normally, which leads to the symptoms of myotonic dystrophy type 1. Case 5, an 8-year-old boy presents after a witnessed GTC. His parents state that the patient reported nausea and hearing sounds like splashing water before the seizure, and he's had several episodes of similar auditory hallucinations in the past. Examination reveals multiple angiofibromas on the nose and cheeks, and a 1 centimeter axillary cafe au lait spot. His MRI brain shows subependymal nodules and hyperintensities at the cortical-subcortical junction on T2 weighted imaging. So this patient has tuberous sclerosis complex. Clinical clues for TSC include skin abnormalities such as the hypopigmented macules, angiofibromas, Shagreen patches, and ungual fibromas, retinal hamartomas, renal malformations, including angiolipomas, cysts, and renal cell carcinomas, subependymal nodules, cortical dysplasia, seizures, subependymal giant cell astrocytomas or SAGAs, rhabdomyomas, arrhythmias, and multifocal micronodular pneumocyte hyperplasia, as well as behavioral disturbances. The genetic mechanism of tuberous sclerosis is shown here. So tuberous sclerosis is caused by a heterozygous loss of function variants in the TSC1 or TSC2 genes. Both genes are important for regulation of cell growth through the mTOR pathway. Genetic diagnosis can be made through targeted single gene testing, panel, or exome. Patients with TSC have pathogenic variants in either TSC1 or TSC2, but not both genes. And these pathogenic variants functionally inactivate TSC1 or TSC2 or lead to the loss of the ideal conformation of the Hamerton-Tuberin complex, causing aberrant activation of the mTOR pathway, resulting in heightened cell proliferation and growth. It's autosomal dominant inheritance, and variants are de novo in 2/3 of cases. Determining if the variant was de novo or inherited can provide important information regarding reproductive risk and risk of phenotypic manifestations and the need for surveillance of other family members. Associated features requiring investigation or monitoring or surveillance include CNS tumors, seizures, renal screening for angiolipomas and cysts, cardiac evaluation for rhabdomyomas, and then cardiac electrophysiology for arrhythmias. There's a potential role for targeted pharmacotherapy with mTOR inhibitors, and there's clinical trials examining the efficacy of mTOR inhibitors, which have shown evidence to support the use of these, specifically for treatment of SAGAs, renal angiolipomas, skin malformations, and epilepsy. Case 6 is an 18-month-old girl presenting for evaluation of global developmental delay. She makes some cooing verbalizations, often smiles and laughs, but does not babble, and does not yet sit independently. She has light-colored hair, blue eyes, and a small head. Examination reveals axial hypotonia, brisk reflexes, and jerky movements of the limbs. She has a brain MRI that's unrevealing, and EEG is shown with notch delta activity. This patient has Angelman syndrome. The clinical features of Angelman syndrome include developmental delay, problems with speech and balance, intellectual and cognitive disability, and seizures. Many people with Angelman syndrome laugh and smile often, and they tend to be happy and easily excited. Developmental delays clinically begin about 6 to 12 months of age and are often the first sign. Seizures can begin around age 2 years. Cases of Angelman are often caused by de novo deletion of the maternal chromosome 15 or paternal uniparental disomy. Features of Angelman syndrome result from deficit expression of function of the maternally inherited UBE3A allele. Molecular diagnostics for Angelman syndrome include epigenetic testing with methylation-specific MLPA, and the diagnostic algorithm for clinically suspected cases is shown here. For suspected Angelman syndrome cases, methylation analysis of chromosome 15q11 to 13 region can be performed using the methylation-specific MLPA, and about 70 to 75% of people with Angelman syndrome have a deletion and are missing a segment from chromosome 15. For those with abnormal methylation results, these abnormal methylation results and then have a deletion. For those with the abnormal methylation results and no deletion detected, so for those with abnormal methylation results and a deletion detected, it's usually, it's diagnostic of that. For those without a deletion, there's another test, it's called a microsatellite linkage analysis. It can be performed to differentiate paternal uniparental disomy from imprinting defects. For those with normal results of methylation, the UBE3 gene sequencing is recommended to detect a UB3A gene mutation to look for the maternal change. And if it's not detected, then Angelman syndrome is excluded and other diseases need to be considered. Case 7, a 4-year-old boy presents with toe walking, difficulty running, proximal muscle weakness, calf hypertrophy is noted on his exam, and his serum creatinine level is 12,000. So this patient has Duchenne muscular dystrophy. Clinical characteristics of Duchenne muscular dystrophy include calf hypertrophy, positive Gowers maneuver, which you can see this little boy doing here, lordotic posture, toe walking, an abnormal waddling gait in the setting of grossly elevated CK, typically elevated to 50 to 200-fold above normal levels. Dystrophinopathies are X-linked recessive disorders. There's no male-to-male transmission. Males are predominantly affected, and daughters of males are obligatory carriers. Females can be affected and are termed manifesting carriers, and this is due to skewed inactivation of the X chromosome. Affected females typically have milder and much later symptom onset than males. Deletion of one or more of the exons, large deletions, are the most common cause, accounting for 60 to 70% of all patients. Duchenne muscular dystrophy occurs when out-of-frame deletions disrupt the reading frame. So this results in a premature stop codon and subsequently no dystrophin protein production. Becker muscular dystrophy, on the other hand, occurs when in-frame deletions still preserve the reading frame. Transcription and translation can still occur, but the protein product is shorter than normal. And duplications of one or more exons, large duplications, occur in about 5 to 10% of patients, and then point mutations occur in about 20 to 30%. This diagram shows the diagnostic decision tree to confirm the genetic diagnosis of dystrophinopathies. Boys with typical symptoms of dystrophinopathy and increased CK level should undergo genetic testing to confirm the diagnosis. Initially, MLPA or array CGH should be used to identify the causative DMD copy number variant, which is the large deletions most often. However, if a causative variant is not identified, which occurs in about 25% of patients, small variant analysis should be used, so gene sequencing. And then boys without an identified causative variant, but still a high clinical suspicion, should undergo a muscle biopsy to detect absent or reduced dystrophin and or protein or mRNA analysis. There are therapeutic implications of this diagnosis, so exon skipping or gene therapy are available depending on the genotype of the patient. One example shown here is eteplirsen, which is an antisense oligonucleotide that binds to the complementary pre-RNA. It's variant specific and can be used in about 14% of DMD patients. Some variants in DMD result in shifting of the reading frames and premature stop codons in the exon 51. And so binding of eteplirsen to exon 51 results in exon skipping of 51, and thus the reading frame is restored, and translation can continue, but the dystrophin protein is shorter than normal. So in other words, skipping of exon 51 is an attempt to convert Duchenne muscular dystrophy to a milder phenotype of Becker. Case 8 is a 6-week-old baby who presents with severe generalized weakness of all 4 extremities, flaccid hypotonia, poor suck, and weak cry. Examination is notable for bell-shaped abdomen and tongue fasciculations. There's some videos here. You can see the bell-shaped abdomen, no anti-gravity movements there, no movements laterally in this patient's head. And the diagnosis is spinal muscular atrophy. SMA has a typical onset in childhood, and clinical clues include lower motor neuron weakness, floppy baby, tongue atrophy, fasciculations, the bell-shaped abdomen due to abdominal rather than chest muscle respirations, bulbar weakness, swallowing difficulties, and scoliosis, especially in type 1 and type 2. Historically, SMA is classified by the age of onset and maximal motor milestones that are achieved. SMA is inherited in an autosomal recessive fashion. This schematic here depicts the SMN genes. There's 2 different genes, SMN1 and SMN2, the mRNA, and then proteins in both healthy and affected SMA patients. Pathogenic variants in survival motor neuron 1 or SMN1 gene which is located on chromosome 5q13, are the cause of SMA. Homozygous loss of exons 7 and 8 in SMN1, or just exon 7 are detected in the majority of patients, so that's responsible for approximately 95% of cases. SMN1 loss occurs due to either deletion or conversion to the SMN2 protein, which is the homolog of SMN1. And SMN2, shown here, has nearly the identical sequence, except for 5 nucleotides, which do not have an effect on the amino acid sequence of the encoded SMN protein. However, there's a C to T transition in exon 7 of SMN2, which disrupts the splicing of SMN2 pre-mRNA. That leads to exclusion of exon 7 from the transcripts, and that results in nearly 90% of the protein synthesized from SMN2 mRNA being truncated, and then only 10% of full-length protein produced, which is not adequate to compensate for loss of SMN1 function. SMN2 has a variable number of copies in the human genome, so higher copies of SMN2 are correlated with milder phenotypes of SMA due to an increased amount of full-length SMN being produced by that protein. Therefore, it's defined, SMN2 number is defined as a prognostic factor for SMA. Specific testing is required to detect SMA. It's often on newborn screens, but it needs to be tested for confirmatory testing with MLPA, which is the gold standard for SMA diagnosis. It can detect SMN1 copy number, investigate the mechanisms responsible for SMN1 loss, so as a deletion or a conversion to SMN2. It can evaluate for the SMN2 copy number and determine the extent of the deletion in that region. This also has a therapeutic implication. It's an important disorder not to miss, as there's treatments available, and these treatments include exon integration treatments or gene transfer therapy. Nusinersen and risdiplam work by promoting inclusion of exon 7 during alternative splicing of SMN2, thereby increasing the full length of SMN protein and thus converting a severe form of SMA to a milder form. There's also gene transfer therapy with Zolgensma, which is returning SMN1 using an AAV9 viral vector. Case 9 is a 17-year-old young man who presents with facial weakness, asymmetric scapular winging, mild foot drop, atrophy of the biceps, triceps, and pectoralis muscles. His CK is mildly elevated. His EMG shows short duration, low amplitude polyphasic motor unit action potentials. This patient has FSHD. Clinical signs of FSHD include facial weakness, scapular winging, and polyhill sign, which you can see here. It's characterized by 3 humps due to relative sparing of the distal deltoid, with atrophy of the proximal deltoid and wasting of the trapezius. Other clinical signs include the BVOR sign, which is upward movement of the umbilicus when the patient is sitting up. And patients can have high frequency hearing loss and retinal vasculopathy. And CK is often elevated up to 5 times the upper limit of normal. This patient that was presented has pediatric FSHD because symptom onset was before 18 years, but it can occur as early as infancy. Onset is across the lifespan with the characteristic face, shoulder, upper arm, and distal leg slowly progressive weakness with variable severity, and weakness can be asymmetric. This is an autosomal dominant toxic gain of function disorder. The genetic diagnosis requires special testing for FSHD, which is directed at that gene, and specifically tests for the number of repeats and the 4QA haplotype. And so this image is depicting the genetic mechanism of FSHD. So in a healthy individual here, there's the normal number of repeats of the D4Z4 region, and it characterized, has closed or tight chromatin, which are these like blue triangles here, and results in no DUX4 gene expression. FSHD is caused by contraction of the microsatellite D4Z4 repeats and leads to hypomethylation of D4Z4 region. And when in the presence of this 4QA allele, results in the expression of DUX4A, which acts as a toxic protein. And the presence of the A rather than the B allele is required for polyadenylation and stabilization of the DUX4 transcript for it to be produced. FSHD2 is caused by variants in a genetic modifier, this SMCHD1 gene, which leads to reduction of the methylation as well of the D4Z4 region and opening of the chromatin and subsequent gene expression, and the production of the DUX4 transcript and the DUX4 protein, and also requires the 4QA allele. FSHD accounts for 95%, FSHD1 accounts for 95% of FSHD patients. The remaining 5% are FSHD2. And last case, case 10, is a 6-year-old girl who presents with weakness and numbness in all extremities, more prominent in the distal legs. Sensation is reduced distally. She had a sural nerve biopsy that was performed and is shown here. And you can see the clinical features here. This patient has CMT1 type 1A. This nerve biopsy shows onion bulb formation, which is due to proliferation of Schwann shell processes. And this feature represents repetitive demyelination and remyelination and is indicative of a chronic demyelinating neuropathy. Clinically, difficulties standing on the heels is indicative of ankle dorsiflexion weakness. She has prominent Achilles contractures, and then feet often show this cavus deformity and toe clawing, which are signs of CMT. CMT1A is an autosomal dominant disorder caused by duplication of the PMP gene, and copy number variant testing is necessary for diagnosis. Duplication of the PMP2 gene leads to overproduction of the PMP22 protein, which is essential for the structure of peripheral nerves. The disease process is characterized by demyelination of peripheral nerves, which means that the myelin sheath is insulated, that insulates the nerve fibers is damaged, affecting the nerve conduction. Patients with CMT1A may experience symptoms of muscle weakness, atrophy, and sensory neuropathy disturbances. So some key takeaways that we hope you take away from this lecture. The clinical picture should always guide your workup. It's important to understand the family history and patterns of inheritance of disease, and that will help guide which testing you select and who in the family you should be testing. It's important to know that the limitations of different testing modalities and the diseases that will be missed if you just send Wes alone. Oftentimes we hear the whole exome sequencing was negative and therefore the patient doesn't have a genetic diagnosis, when in fact it might be missed because whole exome sequencing is limited. Understanding when specific testing needs to be ordered, if there's a suspicion for a specific category of disease or a specific disorder, you should be sending the appropriate testing that will look for that disease or disorder. Here are our references, and that is all. Thank you for joining. Thank
you so much, Dr. McAnally. And I think we do have one question in the chat. And the question is, why muscular dystrophy occurs later in life in girls than in boys? Do you want to try to answer that? I can also add.
Feel free to add your input.
Okay, so just to clarify, muscular dystrophies, I'm guessing the question is mainly for the Duchenne muscular dystrophy, right? Because this is an X-linked disorder. And that's true when we have female that manifest disease, when the inheritance is X-linked, many times they're going to be asymptomatic or mildly affected and later in life, as we sometimes see with Duchenne or with X-linked myotubular myopathy. That's another disease. For the other types of muscular dystrophies that are not X-linked, just to clarify, usually the age of onset is just the same as boys. And the reason that with X-linked inheritance, when they manifest later, usually the genetic mechanism behind that would be X inactivation that can, and this kind of mechanism is a bit more complex, but usually girls have a compensatory X chromosome, and with X inactivation, it's limiting how much it can kind of compensate for the one X chromosome that actually carries the variant, the pathogenic variant. So if it's very much inactivated, let's simplify like that, they can even manifest quite severely, even as severely if it's full inactivation, they can present like boys. But if it's only like 40% or 30%, then we may see symptoms, but later in life. And that would be a key for why girls could manifest later in life. I hope that answered the question.
All right. Well, thank you so much again for joining, everyone. And we will see you on the next webinar. Thanks so much. Take care.
Thank you very much.
Thank you.